Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant for acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum, dean of Sama Institute of Health. We are still doing our session on basic emergency care course. This is last presentation in shock. The objective of this session about shock to recognize sign of shock and poor perfusion, perform critical action for patient with shock, assess fluid status, select appropriate fluid administration based on patient age, weight, and condition, recognize malnutrition, anemia, burn, and adjust fluid resuscitation accordingly. Here we're going to discuss management of shock and specific intervention. Always you're going to start in any critically ill patient with ABCD approach. When you find a problem, you fix it, and then you move to the next problem. While you are managing your patient or doing assessment, if you discover a problem, go back to the ABCDE approach. For all causes of poor perfusion, always get an IV line and start an IV fluid, ringer lactate, normal saline for most or for all adult plus children with non-nutritional status. Then, or at the same time, you want to find the underlying condition and manage it. If you are in low resource area or you cannot establish an IV fluid, consider rehydrating by interosseous or nasogastric tube. If patient is not in severe shock and it's safe to give him orally, sometime you can consider oral hydration. So for patient with shock, especially there is no malnutrition or severe anemia, set an IV line, set an IV fluid. If IV fluid is immediately start the IV fluid and reassess, give a bolus 500 and repeat, assess after 30 minutes, reassess if the patient improve, and if the perfusion improve, then you can switch to oral. If you cannot establish an IV fluid, then if you can transfer to a nearby facility quickly, you can do that, and you can do that safely to arrange for transfer. In some patient, you can put an NG tube, like those with cholera in epidemic, you can put an NG tube and start enteral hydration. Always reassess your patient. Ladies with postpartum hemorrhage, if your facility can handle them, start by establishing an IV line, give IV fluid, and try to control the contraction of the uterus by giving oxytocin or doing uterine massage. You can give repeated doses of oxytocin, and sometimes you need to give continuous infusion of oxytocin. Assess if the placenta was delivered or not by contracting the uterus by massage and oxytocin. This can induce contraction and delivery of the placenta. Try to collect it in a clean bag and transfer it with the patient if your facility cannot handle this kind of patient. With severe bleeding, you need to arrange for blood transfusion, and then you need to assess if you can handle the patient in your facility or to transfer to another facility. Patient with burn, burn as it disrupts the skin, it can lead to significant fluid loss. Calculate the fluid loss by Parkland formula, and you have to give replacement plus the maintenance fluid, and also always consider if you will handle the patient in your facility or to transfer to another geographical area. Patient with severe hyperglycemia and diabetic ketoacidosis, if they are in shock, you need to give aggressive fluid hydration, and then you need to manage by giving electrolyte correction and insulin and other, if there is an infection, you treat that. When you suspect sepsis, the first line is fluid resuscitation, and after that you need to identify the source and give a antibiotic according to the most likely source. Sometime in those with sepsis, if there is an abscess that need to be drained. Patient with suspected spinal cord injury, this can happen in a context of trauma. You need to follow trauma protocol. Those with cervical spinal injury, they need usually they get hypotension and bradycardia, and they need significant amount of fluid. And those with suspected internal bleeding from portal hypertension, hematemesis, or even rectal bleeding, hematochezia, you need to give IV fluid and arrange for blood transfusion. And then you need to transfer for endoscopy and further management. Patient with pneumothorax, you need to give them oxygen, you need to give IV fluid and needle decompression, and then to establish or to place a chest tube. Suspected pericardial tamponade, IV fluid to improve cardiac filling and cardiac output, and they give oxygen. And if there is resources for pericardiocentesis, you do it or you transfer to appropriate facility. Patient with suspected heart attack and cardiogenic shock, give oxygen, give aspirin. And the problem here, the shock can happen in the background of pulmonary edema. If there is fluid overload, you might need to go to inotrope. But if the patient have relative fluid deficiency, you can give gentle hydration. The same those with cardiomyopathy and cardiogenic shock. So if there is relative intravascular volume depletion, you give gentle hydration. But if they are overloaded, you might need to go to inotrope or to transfer to facility where they can receive appropriate treatment. Those with allergic reaction and anaphylaxis, you need to establish an IV line, adrenaline, and sometime when the airway and breathing is affected, also you need to give oxygen. Trauma can lead to overt bleeding, external bleeding, and also can lead to concealed bleeding in the thorax, in the abdomen, in the pelvis, in the thigh. Give IV fluid and arrange for blood transfusion. If the bleeding is obvious, you need to do compression or use tourniquet. And then surgery assessment is needed, and then decision about where you can treat this patient. People with shock who can worsen quickly, so continuous monitoring is important. Illness that cause shock can also cause other problem. It can lead to difficulty in breathing, like allergic reaction, like trauma, like sepsis. All these can affect the respiratory system and can lead to shock at the same time. Then assess the resources, if you can handle the patient in your facility or you can transfer. And when you transfer, follow appropriate protocol and communication and handover. Take home, critical action for managing shock always start with ABCD approach. Then in the secondary survey, do sample history, surely assess sign and symptom, assess for allergy, medication, past medical history, when was the last time the patient took oral intake, and events surrounding the condition, and do secondary exam to look for any clues. Give oxygen as needed, establish an IV line. If it is difficult to establish a line and you don't have resources for central line, place an interosseous, and in some situation you need to put an NG tube and hydrate accordingly. In patient with allergy, give adrenaline. Those with sepsis, use antibiotic, again is the appropriate source after initial hydration. Postpartum hemorrhage, as you are managing the shock, consider or try to establish uterine contraction by oxytocin and massage and delivering of the placenta. DKA, treat with IV fluid and electrolyte and insulin. Trauma, you need to control the external bleeding by applying pressure or tourniquet. Pneumothorax, needle decompression plus chest tube, tamponade, drainage according to resources. And in burn, you need to, for patient with burn, you need to calculate the fluid loss. Thank you.